Okay, so welcome. We are going to have some redistribution of the 2 hours like Yelini said. We encourage some participation like always, but today even more. We have unfortunately 2 speakers that couldn't make it to the meeting. So it will be reduce the amount of presenters, however, it's going to allow more opportunity for discussion. There are people like Dr. Jones, very involved in Fuse, that we will make him to give some opinions about that later on.
Absolutely.
So here I have a distinguished panel here with K. Mary King, Chairman at Albany Medical Center, Dr. Kevin Hayek, Chief of Surgical Endoscopy and Hepatobiliary Surgery at Metro Health in Case Western Reserve University, Yelini Visnegam. She is an assistant professor at University of Chicago, very talented young laparoscopic bariatric surgeon, and Dr. Aurora Pryor, Chief of Surgery at Stony Brook, and my friend John Romanelli, University of Massachusetts. So, Bay State Medical Center. So, we are going to start with the first presentation. That is going to be John Romanelli. Oh, you have it.
Thank you very much for the opportunity to speak today, and thank you for that kind introduction. I only have one disclosure. It's not relevant to this talk. I'm happy to have more disclosures if anyone wants to bring them my way. I always like to start talks like this with a quote, and I like the quote, "Chance favors the prepared mind." So think about that when you're thinking about hiatal hernias in bariatric patients. So here's a case report. 53-year-old woman, body mass index of 42. She's interested in bariatric surgery. Has a long history of gastroesophageal reflux disease. She's on omeprazole twice a day. She was scoped within the last year. No evidence of Barrett. She had grade A esophagitis, moderate-sized hiatal hernia. Not interested or willing to have a gastric bypass. She wants a sleeve gastrectomy. And by the way, she's my medical assistant. Okay, so to make it more complex, this is a lady I work with. And this is her barium esophagram, which shows a large type 3 paraesophageal hernia. We also got a CAT scan, which confirmed that it was not a type 4. There were no other viscera in the chest. So what would you offer this patient? You could do a paraesophageal hernia and then go on to do a gastric bypass, but she really doesn't want that. You could do a paraesophageal and then do the sleeve that she wants, but your risk of sleeve reherniation later on is relatively high. And the recurrence rate for paraesophageal hernias is 25% as it is, and now you've got limited options to re-repair it should you herniate the sleeve. Or you could just repair the paraesophageal hernia alone and plan to come back a later day to do the sleeve, and that's what the patient chose, and we're going to probably wait 1 year and let her take her time going through the bariatric program while she heals from the hernia. And just to review the bariatric operations for those of you that aren't bariatric surgeons, gastric bypass makes a small gastric pouch, generally inferior to the left gastric artery. The jejunum is divided about 25 to 50 centimeters distal to the ligament of Treitz. The distal end is then brought up in anastomosed to the gastric pouch, making a gastrojejunectomy. And then the biliopancreatic limb is anastomosed to the roux limb, 75 to 150 centimeters downstream. Sleeve gastrectomy is now the most common operation performed worldwide for bariatric surgery. And in this, the attachments from the greater curvature of the stomach are taken down all the way up from the antrum, all the way up to around the left cruce of the diaphragm. And all the short gastric vessels, which would be right up in this area, would be divided. A bougie is placed inside the stomach along the lesser curve, ranging from 32 to 40 French, based on surgeon preference. And the stomach is divided from the antrum all the way up to the cardia using surgical staplers right alongside that bougie. And the specimen's then removed. Pretty simple and straightforward. There's also biliopancreatic diversion with duodenal switch, which I'll keep these remarks a little bit more brief, but essentially it's a larger sleeve gastrectomy and a duodenal ileostomy. The feature of this is a short common channel and a relatively long biliopancreatic limb. That's more of a malabsorptive type procedure, and often it's now performed with a loop anastomosis, which they call single anastomosis duodenal ileostomy, or SATE. So your pre-op workup, first of all, take a good history. I mean, that's sort of obvious, but a lot of obese patients have obesity-related dyspepsia. They don't necessarily have pH-proven gastroesophageal reflux disease, so they have a little mild heartburn. Their primary care doc puts them on proton pump inhibitors, but they don't necessarily have a diagnosis of gastroesophageal reflux disease. Get a barium esophagram to characterize the size and type of a hiatal hernia should they have it. Even patients with obesity-related dyspepsia should have it because they may have a hiatal hernia that's undiagnosed. I also find it helpful to see if they reflux the column of barium because it gives you a degree of knowledge as to how bad the disease is. They should be scoped within the most recent year. You need to both rule out Barrett's esophagus and severe esophagitis. Now, the question is, should all people that's going to undergo a sleeve gastrectomy get an upper endoscopy preoperatively? And I think that's controversial from a cost-benefit standpoint, although we'll review some recent comments made in consensus conferences about that in a minute. I would consider a pH study if you did not find a hiatal hernia, although if the patient's going to undergo bariatric surgery, I'm not sure of its value, and esophageal manometry probably is not necessary in this setting. Now, remember that all bariatric operations take place near the hiatus. One of the key points about post-bariatric anatomy is that every bariatric operation has to involve the cardia of the stomach, and so therefore you're working right near the hiatus. And the reason for that is because stretch receptors in the cardia stimulate satiety in the brain, right? It makes sense. If the very top of the stomach is full, the brain needs a signal that you should stop eating. So everything we do in the bariatric world involves the cardia. So given that, hiatal anatomy is highly relevant to what we're going to do in the operating room. And that's a nice picture of a small hiatal hernia, but the cardia is all the way up here in the chest. So if you were to just amputate this and make a gastric bypass pouch, you'd have problems. And just to review the hiatal hernia, is a type 1 sliding hiatal hernia, the gastroesophageal junction, which is listed as displaced, and actually this is displaced because the GE junction is really here, not where it's pointing. But this slides back and forth from the peritoneal cavity and up into the mediastinum, and that's the main feature of a sliding hernia. Eventually, over time, they stop sliding. Now, this is a type 2 hernia where you have a juxtaesophageal portion of the stomach, and these are very rare. They only present about 1% of the time. Most common is the type 3 mixed paraesophageal hernia, where the GE junction is above the diaphragm, but there's also stomach herniated next to the esophagus. And then over time, other viscera like the colon can go up in the chest, and this also represents a gastric volvulus, and that's a type 4 hernia. So I want to talk philosophy for a moment. Type 1 hiatal hernias are basically a physiologic disease. In other words, the patients are suffering from reflux for physiologic reasons, typically at low lower esophageal sphincter pressure. Their symptom is primarily heartburn, but it can include other symptoms such as regurgitation and water brash. The anatomy does matter to the bariatric operation, but the point of an operation for reflux is to address the physiologic problem. So to strengthen the sphincter with either a fundoplication or magnetic sphincter augmentation or something like Stretto or TIF. But type 2, 3, and 4 hiatal hernias are an anatomic disease. It's a different disease, and you have to think about it differently. The anatomic defect is the problem, and restoration of anatomy is your operative goal. Now, while these people can present with heartburn, often they have dysphagia, regurgitation, or chest pressure, other symptoms, not typically heartburn as the primary presenting symptom, sometimes, but not commonly. So given the problem with the anatomy, anatomic restoration is critical to a bariatric surgeon, although you must be mindful of the physiologic changes from both the hernia repair and the bariatric procedure. So it's important to think about these differently. Now, in reviewing the anatomy of the lower esophageal sphincter, I really like this slide that came out a few years ago. We talk about things like the clasp fibers and the sling fibers, but many people don't really understand where they are or why they're relevant. So remember, the esophagus has two muscular layers, an inner circular muscle layer and then an outer longitudinal muscle layer. And the distal esophageal circular fibers then cross the angle of His and form the sling fibers on the stomach, and these are really critical to prevention of reflux. The clasp fibers are a little bit lower down and also are thought to have some role in anti-reflux mechanisms. And then, of course, remember the diaphragmatic crura wrap around the esophagus as it comes out of the chest and into the abdominal cavity. And you can see that with the 3D reconstructive view of it right here. So I wanted to show you a couple of images. These are things we see in bariatric surgery a fair bit. I like to call the first one the anterior dimple. You can see the right crus is prominent, and then you see this little dimple of peritoneum, and if the liver was retracted a little better, you'd see the left crus right here. And there's just this little indentation or dimple. That's a hiatal hernia. Now, when you put the patient in reverse Trendelenburg position, it often disappears as gravity pulls the stomach away, so you need to look at it in the supine position to see if it's present. This is a little more obvious. That's a true punched-out defect, so I would call that an anterior defect. So what do you do with the dimple? Most bariatric surgeons would consider that a true anatomic defect, and they would repair it. As I mentioned, in reverse Trendelenburg position, the hernia will self-reduce by gravity, and so you may not see it, you may not catch it if it's a small little dimple. And then, the question you have to ask is mobilizing the hiatus and the distal esophagus going to leave you with less of a natural barrier to reflux than what you had? So in other words, are you going to dissect and worsen the problem rather than leaving them with a minor problem? Now, the anterior cruroplasty has been reported in this situation where you open the peritoneum and then suture the right and left crura together anteriorly, but there's really no data to suggest it does anything to reduce reflux. And by the way, you can't bill for a separate procedure, which is why people are kind of coming up with these, well, not why, but one reason why people are coming up with these little modified hiatal repairs is it's not billable anyhow. So, and this is what an anterior cruroplasty stitch would look like, where you take a bite of the right crus and a bite of the left crus and suture them together with something like silk. There's really not great literature on it, and in fact, you can cause reherniation if it's too tightly closed, which I'll mention in a case report in a minute. And it doesn't actually mobilize the gastroesophageal junction, so if you do this, the cardia is still up here in the chest. What does the data say on anterior repair? This came from the Michigan Bariatric Quality Collaborative, where they looked at over 7,000 patients who underwent sleeve and hiatal hernia repair concurrently, and 5.3% of those patients had an anterior repair. And these are two direct quotes from this paper that came out last September. But patients undergoing sleeve with concurrent hiatal hernia repair by surgeons who typically perform an anterior repair were more likely to report worsening gastroesophageal reflux disease at 1 year despite excellent weight loss. And then surgeons who performed an anterior repair had nearly 1/2 of their patients reporting increased GERD severity. So the data is not encouraging for that. And here was a case report from Turkey that came out about 6 months ago, where they closed anteriorly and the patient had a vomiting episode because it was closed too tightly, and they forced the stomach to migrate intrathoracically and had to emergently reoperate on the patient. And really the point of the paper was that an anterior repair was the wrong thing to do for this patient. They should have had a formal posterior repair. And when we talk about posterior repair, you open the gastrohepatic ligament, which in this photo is already opened. You identify the right crus. You take down circumferentially from right to left, although some people go left to right, but up and over, taking down the phrenoesophageal ligament, which is located here, and mobilizing the phrenoesophageal fat pad. You mobilize the stomach and divide all the short gastric vessels. You completely free up the left crus posteriorly. You dissect the esophagus until you have 2 to 3 centimeters of intra-abdominal esophagus, and then you close the hiatus posteriorly with non-absorbable sutures. Now, what about doing a sleeve gastrectomy and a concomitant hiatal hernia repair? This is a bunch of data from different studies, but I wanted to read some of this to you. If a hiatal defect is encountered during a sleeve, it should be repaired with non-absorbable sutures during the same operation. That comes right out of the SAGES manual for bariatric surgery. At an international sleeve gastrectomy expert panel consensus in 2011, they tackled this question, and 82% of the experts at the consensus felt that a concomitant hiatal hernia repair should be repaired at that setting. After 5-year follow-up, hiatal hernia repair during sleeve gastrectomy success rates were 82% for a posterior sutured hiatoplasty. So the results are pretty good. But, and there is a but, look at these bottom two comments. Symptoms did not improve in 76%, small study, only 26 patients, but 76%, their symptoms didn't improve with a concomitant hiatal hernia repair during sleeve, and new onset reflux was detected in 16% of 32 previously asymptomatic patients. That's a little discouraging. After a minimum follow-up of 6 months, the prevalence of gastroesophageal reflux in the sleeve gastrectomy and hiatal hernia repair group did not change, but it showed a significant decrease in the sleeve-only group. Hiatal hernia repair could be a promoting factor in the development of gastroesophageal reflux. It's a little bit of a leap in logic I'm not sure I agree with, but certainly the data is not that great on concomitant repair, so it leaves you in a quandary as to what to do. A couple of years ago, there was a first international consensus conference on reflux and sleeve gastrectomy. 46 experts weighed in on numerous topics. And here was one that was, I thought, pretty critical, that esophageal gastroduodenoscopy was considered mandatory before a sleeve. 92% of the experts felt that, and afterwards, 78%. Higher degrees of erosive esophagitis, and that's grade C or D, and Barrett's esophagus were viewed as contraindications for sleeve gastrectomy. That's why it's critical to scope these patients before you offer a sleeve. It provided to have a history of reflux, that is. Now, Roux-en-Y bypass was recommended in post-op patients with uncontrolled reflux and insufficient or sufficient weight loss in Barrett's esophagus. And these are all greater than 3/4 of the experts agreed with this. Hiatal hernia was deemed necessary even in asymptomatic patients without reflux. 80% for large defects, 67% for small. And a modified sleeve with a fundoplication in patients with GERD was considered by 77% of the panelists. That is not yet caught on in popularity, but you're starting to hear more people report that they're trying this. Now, you could do a bypass at the same time as a hiatal hernia, but there are pros and cons. Certainly a pro is that you're less likely to reherniate up into the chest. And the weight of the roux limb and the downward pull from the ligament of Treitz and the mesentery of the small intestine helps keep the stomach down into the abdomen. And you also still have the fundus available. You haven't resected it like in a sleeve. So if a reherniation occurred, you could potentially do a fundoplication with the remaining fundus above your gastric bypass pouch. Cons, though, it's a more morbid case with higher long-term complication rates. We've known that for many years. It takes considerably longer to perform. And adding a long case after doing a difficult paraesophageal hernia repair, and the difficulties due to BMI. These patients have a large degree of visceral fat, making the view much more difficult. It can be a lot of surgery for patients that are sicker patients and higher risk. And you may not want to use mesh there in the GI, as the GI tract was open for the anastomoses. So if you have a defect that's difficult to close, your mesh options become complicated. Here's a paper that shows, this is UHC data. This paper came from the University of Nebraska from 2006 to 10. 33,000 patients underwent bypass and did not have a hiatal hernia, compared to 644 patients who did have both a bypass and hiatal hernia repair. And 1,589 patients underwent bypass without repair of hiatal defects. They were left alone. And there was no difference in mortality, morbidity, length of stay, readmission rates, or cost that was shown in this study. On comparison of the patients with hiatal hernia who underwent bypass and simultaneous repair, compared to those that had the bypass and did not have a repair, there was also no difference in outcomes. So the conclusion is hiatal hernia repair appears to be safe and feasible, but I would argue that deferring the hiatal hernia repair also seems safe and feasible, so I'm not sure this answers the question well. Now, is there a role for mesh repair of the hiatus during bariatric surgery? So this is a study that came out in 2021 that looked at a prospective database in a single center of 1,800 bariatric operations over an 8-year period, and 250 had concomitant hiatal hernia repair, so 13% of them. 151 of those cases were posterior repair with sutures only, and 99 of them were reinforced with bioresorbable mesh. And posterior repair alone failure with intrathoracic migration of the sleeve happened in 12 cases, 8% of the time, whereas it was only 4 cases, 4% of the time with mesh repair. So this paper does recommend the use of bioresorbable mesh given the high recurrence rate due to the fact that the patients are obese. So a few conclusions. The question is, what do I do? So I do believe in repairing them at the time of bariatric surgery. But if it's a large enough hernia, considering just fixing a paraesophageal hernia repair and coming back to fight another day for the bariatric operation is not unreasonable. Preparation is key. Take a good history. Make sure they've been endoscoped. Get a barium swallow before surgery. Make sure you know what the patient's anatomy is before you make a concrete recommendation as to the bariatric choice. Proper informed consent with the patient won't happen unless you're armed with their anatomic information preoperatively. The anterior choroplasty should be strongly discouraged. If it's a large paraesophageal, I think gastric bypass is the preferable option due to concerns of reherniation of the sleeve into the chest. Barrett's esophagus and severe esophagitis, grade C or grade D, are considered contraindications to doing a sleeve gastrectomy, and I would consider bioresorbable mesh to reinforce the repair. Thank you very much. I think we'll do questions after Dr. Pryor's talk. Is that the plan? Okay, thank you.
We'd like to bring to the podium Dr. Aurora Pryor, Chief of Surgery at Stony Brook Medicine, to speak on GERD treatment in patients with BMI 30 to 35.
Yeah, if you guys will pull up the Aurora Pryor talk, that would be helpful. Although I'd love to give John's talk too. I might bring some counterpoints to it.
Can you start the timer?
He's doing, yeah. No, I can't do the timer. So just one little disclosure at the very beginning is I'm actually Surgeon-in-Chief at LIJ. I moved in October over to Northwell, and I'm the System Chief for Bariatric Surgery there. My topic's a little controversial. I have disclosures, but none are actually relevant to this talk. Probably my most relevant disclosure is that I'm the past president of the Fellowship Council, and even though we're talking on clinical topics, this is about training, and I'm happy to kind of pick some of the stuff on training. Specifically, what I'm going to talk about now is the reflux and this kind of controversial BMI 30 to 35. And there are a lot of options that you can offer these patients. So from the training standpoint, I think our fellows need to be aware of all these options so that they can really discuss them in a logical way with their patients. So what are the causes of reflux symptoms? There's a lot of different things on somebody who shows up in your office. And I know often somebody will come to me and think they have reflux, and I'll do testing, and they do not actually have clinical pathology with acid in their esophagus. So these are all things that you need to consider. You heard a really nice talk from John about looking for hiatal hernia as an underlying factor in some of these things. But I do think you have to have all of these considerations, and they should be treated differently depending on what you find. Early on, I think management with medical management is actually important to be aware of. We're here at a meeting with a lot of GI colleagues who probably do this very, very well. But even as surgeons, I think we need to be aware of these measures and try them in our patients and really try to see if there's something we can do. Positional measures, promotility agents, pH, anti-acid agents as well. All of these can add up to actually be successful for some patients. I then do a workup, and I do think really on these patients, which sometimes have other pathologies related, you have to figure out what's really going on and understand your baseline. Upper GI, endoscopy, pH, and manometry for me are essentials anytime you have a reflux patient, and really understanding what's going on with their physiology as well as their anatomy. And then option choices are a lot. Some people think it's pretty easy. I know I was talking to Danny Scott last night at the foundation dinner, and I told him what this topic was. He's like, oh, that's easy. You just do a fundoplication, which is actually a really good option, and in my practice, it's probably the number one choice. But I think all of these things have a place, and you have to figure out what's the right choice for your particular patient. So I do think Nissen or Toupet, and you can definitely get people who are going to argue very strongly on both sides of this, is a gold standard. It's covered by insurance, so for a lot of our patients, this is going to be the easiest choice, and it works well for most patients. And it's very effective, and it's been done for a long period of time. I think we can spend all day talking about the nuances of these procedures or how to work it up, and probably most of you in this room know this very well. So that's my only slide on the standard care. So now I'm going to talk more on some of the other alternate techniques, because these are what I think we need to have in our wheelhouse, at least for discussion. If you don't do them personally, I think it's fine to work with a team. I think that's the modern practice. They do it in oncology. We can also do it in benign disease and have members of your team that do this if you don't. But I also think that we as surgeons can do all of these techniques too. Endoluminal fundoplication, both of these things have been done in the US. One is definitely much more popular now, the other is primarily in Europe. But the TIF procedure is pretty straightforward with T-fasteners. You heard Nin Win maybe this morning talking about it a little bit about the anatomy of this device and the effective fundoplication that it results in. But it's actually pretty straightforward. It has a little helical retractor that can pull a bite of tissue into the jaw of the device, and then at retroflex it just deploys these T-fasteners to create the plication. And this is the end effect, really good valve, really probably better circumferential on the esophagus than we can do surgically. Has good results over time. Here is a repeat endoscopy 5 years later with really good confirmation of what we would all think is a good wrap with good apposition to the scope. And then here is post-TIF PPI usage in several studies and really a change in the medication management of these patients with good results in their reflux control. Looking at esophagitis control, also good in many of these studies. So I think this is a very viable option for reflux. It's pretty quick, so it takes about as much time as a fundoplication. Complications are very low. And really compared to sham, it's a great study. Long-term data is more lacking, but it's still, there's some. The GERD-RX device, this used to be the esophagus procedure, was done. I learned this in Boston way back when, and this never gained traction in the US, but it's now become more popular in Europe. The company is now located in Germany. And it's a similar thing with a retroflex devices deploying through and has some reasonable changes in pH control and PPI use over time. There have been electrosurgical options, which has, again, kind of come in waves in practice. Anti-reflux mucosectomy's been there with circumferential endoscopic mucosal resection. I would not want that. I would not want my patients to have it, but I think it's good for us to know what it is. There are some stimulation devices and resections that have been done. I think Stretta has been the one of these that has lasted the longest, but still has kind of equivocal results and not really great. But for some patients, particularly post-bariatric patients, I think it's something you could keep in a wheelhouse. This device is one thing that I think most of our fellows and trainees really should know about, because I do think that it's got some potential benefits, particularly for some of our younger patients, and should be something that's discussed. Magnetic sphincter augmentation is a pretty logical thing. It's a new sphincter that's added around the outside of the esophagus and can work well with deployment. It opens up when you swallow and has really some good long-term data in comparison studies. So here is comparing PPI use at baseline and then continuing out to 3 years after the magnetic sphincter augmentation, compared with satisfaction, also on the right side with satisfied, neutral, and dissatisfied, and you can see that patients in general are very happy with this procedure. Here's looking at regurgitation symptoms, dysphagia, and esophagitis, and although some of these are present post-op, they're actually pretty low and reasonably controllable, as you can see from the patient outcomes. And this is here, heartburn, regurgitation, PPI dependence, and dissatisfaction over time, and really pretty good results. And compared with some of the fundoplication things we see, these are really good data. And this is why I think this is something we as foregut surgeons need to know in our practice. GERD, health-related quality of life score, pre and post MSA really has significant improvement over time. And now there are studies comparing fundoplication and magnetic sphincter augmentation. None of these had big hiatal hernias, which is now an approved thing, so you can do these with hiatal hernia. Fundoplication took longer. There are more steps involved. And then relatively good GERD, health-related quality of life at 6 months, with improvements that were relatively comparable for the two groups. Relatively comparable Demeester scores, lower, probably not clinically significant with MSA, but lower gas bloat and improved belching. So again, I think reasonable procedure for us to consider. Quality of life is probably comparable to PAY and maybe slightly better with Nissen from some of the side effects that we may see in some of those Nissen groups, particularly belching and vomiting ability. So those are the common things done for reflux. Now I'm going to get into the bit of the controversy, which is what I think is actually really most interesting when we think about this disease and pathology. And that's what do you do with some of these people that are not standard? So you do this workup and you get something like this. Swallow is terrible. So with esophageal dysfunction, I think it's a good argument, and this is definitely my preferred thing in my practice, even with the lower BMI, is to consider the Roux-en-Y gastric bypass. This is really a really good anti-reflux operation. I had a great talk about this morning. It decompresses downstream. It provides some structure to your diaphragmatic repair. And I do think it's really the procedure's choice in these patients. The trick is it's really not insurance covered. They'll give you some grief about this being a bariatric surgery. And you have to argue, you're not doing this for weight loss. This is not intentionally a weight loss operation. This is something that's going to be low resistance downstream, but still treat the reflux. And for patients with dysphagia, I think this is a really good operation. And so we as foregut surgeons, continuing that message is going to make this easier for us to get through and available for our patients. And there you go, even a good choice in lower BMI. And also it's used for failed fundoplication. So if somebody comes to me, they've had a fundoplication or a hiatal hernia, they recur, and I'm going to redo them. A lot of time you don't know their underlying motility. Sometimes they have dysphagia. I think this is a great operation, particularly for those edge BMI people. So here's some of the reflux outcomes with gastric bypass, looking at a couple studies and the types of bariatric surgery that I included here, which is the gastric bypass. But really good follow-up with reduction of heartburn, 87% down to 22. So not perfect, but good in that study. And improvement in 100% in the other studies. So again, these are really good outcomes, and we should be considering this in the armamentarium of foregut surgeons. Now, low BMI, there's actually a lot of data to support this, even if you're considering it for weight loss or the metabolic effects. So here's some data from National Health and Nutrition Examination Survey, or NHANES. 1 in 3 adults now are overweight, 2 in 5 have obesity. Children, adolescents are also getting this problem. So this is something that is really a phenomenon worldwide. If we avoid those patients continuing with their problem of obesity, we can prevent long-term obesity, we can treat some of the metabolic effects early on and maybe avoid some of those sequelae. And really our surgical cutoffs are really arbitrary. We had qualifications, and most of our insurance providers follow things that were static since 1991. I do feel like we know a lot more about what we're doing now than we did that long ago. And ASMBS and IFSO agree and actually gave us some new guidelines finally in 2022, which I think really opened the door for these discussions and hopefully are going to make some changes for our insurers. So what this guideline recommend, again, international recommendations, that metabolic and bariatric surgery is recommended for individuals with a BMI greater than 35, regardless of comorbidities. So that's dropping down 5 points in BMI from what we consider standard now. If you have type 2 diabetes, there's good evidence to support that a BMI of 30 as a cutoff is very appropriate. Metabolic and bariatric surgery should be considered in anybody regardless of comorbidities with a BMI between 30 and 35. And in certain populations, such as the Asian population, that cutoff should be even 5 points lower because they get metabolic disease earlier than more Western populations. We also supported revisional or adjuvant therapy because obesity is a chronic disease. It's not just a one and done kind of procedure. It's things that you might need other things over time. So revisional surgery is appropriate and should be covered. There's also more recommendations, including adolescents and things from this population, but I think it's very relevant that that BMI cutoff that we currently use is arbitrary. Here's an updated position statement from ASMBS, and maybe this should be the ASMBS SAGES and SSAT discussion today, but that bariatric surgery in class 1 obesity with BMI 30 to 35 is appropriate. And here's some of the data supporting that. So this is looking medical management versus surgical management, BMI less than 35, and shows a change in hemoglobin A1C that's sustainable and better in the surgical group. Probably nobody in this room is surprised, but this is data that's important for us to know so that we can have these discussions when we're doing a peer review to fight some of these cases. Here's looking at the STAMPEDE study, which again, you should be fluent in this when you talk about things. Again, BMI change over time with mild obesity. Here's looking at that STAMPEDE trial data, hemoglobin A1C, body mass index change. And you know that people lose their weight and their BMI goes down, but they're all still in a healthy BMI range and now have hemoglobin A1C in a much more appropriate range for long-term success and control of diabetes symptoms. Here's some of the other procedures: adjustable band, lap sleeve, Roux-en-Y gastric bypass, single anastomosis gastric bypass, which we didn't get in the picture but it's pretty similar, and BPD, looking at changes and analysis of type 2 diabetes, and these are subsets of patients with BMI less than 35. And again, not surprisingly, but here's the data, BMI goes down in all these groups, and there's a weighted mean hemoglobin A1C change that's helpful for our patients. So the summary recommendations from ASMBS is that patients with class 1 obesity require durable treatment for their disease. This is a lifelong disease, and non-surgical treatments don't work, and surgery does. So even in these patients BMI 30 to 35, I think we can easily argue that surgery should be in our armamentarium, and it makes it an even stronger argument that we should be doing this more and more for reflux patients too. So, summary, this is, I think, a good operation, and I'm happy to support it for hiatal hernia, reflux, and lower BMI. So lots of interesting discussion points, and thank you for the time today and the opportunity to present.
Thank you. Okay, very good. So we can start with some questions. I will, if you don't mind, I will start with Aurora, just finished. What happened, Aurora, when you have a patient that has a BMI more than 30? The patient is not willing to have bariatric surgery, gastric bypass. How do you set the expectation on preoperative weight loss, or how do you manage that? Or you go directly to, you are more permissive and you try and give a try? What is your preference?
So I think educating your patients on the options, making sure they're aware, but if they come in with a BMI of 32 when they choose a fundoplication or an MSA, that's not a wrong choice. But I do think it's important to keep an eye on their weight. I'd really rather not be doing a revision surgery. And a whole nother talk I could give on medications for weight loss. I think we actually have some really good adjuncts we can use if they're struggling with their weight, and we can help maintain lower weight over time.
Dr. Soper.
Yeah, Nat Soper from Phoenix. Aurora, I have a couple of questions. Number one, will insurance companies pay for bypasses in patients with a BMI of 30 to 35? Number two, I would think there would be a swell of support from multiple medical societies for the NIH to have another discussion about appropriate bariatric surgery. Is there any such movement?
So thanks, Dr. Soper. Great questions. First one, I don't call it a Roux-en-Y gastric bypass because the definition of 43644 in the book is for obesity. So I'll call it a Roux-en-Y gastrojejunostomy. And usually I can get it covered as that. It's still the appropriate procedure. I'm not doing it for weight loss, so I think it's okay. But I do have a clear discussion of what I'm planning to do, and I label it as such. Number two is we have met periodically with the NIH and review things, but I don't think there's been appetite to write the statement, which is why ASMBS and IFSO pivoted to make the own independent position statement.
I have a follow-up question. So I do similarly to you, if it's below 35, I make sure there's no mention of morbid obesity in the note. It's not the primary diagnosis. And I bill it as a gastrojejunostomy with an in-depth discussion of why we're doing it for reflux. So me and my partners have this discussion because I am a big proponent of this for that population when they have comorbid conditions as well, is do you put them through your bariatric program? And make sure that they're getting all the preoperative requirements and have the same kind of standards for undergoing surgery. Sometimes you'll get that patient that's just so symptomatic And sometimes you want to just jump in there, but you know that they have to have the appropriate education. So how do you manage that?
Yeah, so those are really great questions. I think at a minimum, they need to meet with the dietitian so they understand the dietary changes following. If there's somebody that's getting a revision and they're really symptomatic, I don't necessarily think they need psych. If I can have a logical conversation, I think they understand everything. But if it's somebody that's a little sketchy, I'll send them to psych. If I feel like they're not really compliant, I also sometimes put them in our medical management program. But it's not a requirement for everybody in my practice. It's tailored to that patient's individual needs.
Question for John. You highlighted, and we actually saw this in a much smaller series earlier on, that about anywhere from 50 to 60% of patients are found to have an incidental hiatal hernia. Again, looking at dimple versus not dimple, I think you're splitting hairs there. But do you think there might be a role in not only endoscopy, which can find slightly larger ones, but also upper GI in bariatrics as a preoperative test, just to have more information going in so that you're not surprised when you get there?
Yeah, I agree with that. If they have any symptoms of heartburn whatsoever, any indicator that they have a history of reflux, if they're on a PPI for any reason, I get a swallow on them first. And if I see any evidence of reflux disease or a hiatal hernia, then I make sure that they get endoscoped. I think you need both. I am afraid that we're operating on people with Barrett's that's undiagnosed, and we're doing sleeves, and we're resecting their conduit.
Well, and
So
some of those
I
patients
think,
might not even get an intraoperative endoscopy either.
no, that's true. I agree. So I think more aggressive workup is better. I think we don't want to abuse the cost as well, but I think we need to be very thoughtful and mindful of the refluxogenic effects of a sleeve. And so better to know beforehand that they have a problem rather than discover it after, where you now have limited options to repair it.
Hi,
Jones.
Dan Jones. So, Roy, there is the diabetes paper that has 35 societies, to get to Nat's question, that was endorsed for uncontrolled diabetes. So I think we do have at least an organization that brought 35 groups together to endorse a different set of criteria than NA1. And John, you're a little funny business with your pictures there, because you talked about the dimples, and then you show me a 6-centimeter hiatal hernia with a closure. So the truth is, you see 1-2 centimeter defect, as long as you've mobilized it, GE junction, 1 or 2 sutures anteriorly. Trust me, you're not getting 50% reflux. It works beautifully. Very simple, 1 or 2 stitches. And for 1 or 2 stitches, you probably don't deserve to get paid extra.
No, that's true. But, the concern that I have with doing 1 to 2 sutures anteriorly is that you may angulate the esophagus in so doing. And so I think you have to be mindful of the dissection to see where the repair makes the most sense. My concern about the anterior choroplasty is that the esophagus doesn't get dissected. And so it's a repair without dissection, which I think is an inadequate repair. And the data on it suggests as such.
But I have a question for you, John. So let's define better what is a hiatal hernia repair. Because every stitch in the hiatus, if not, is going to be a hiatal hernia repair. And that's why we have this difference in outcome. So I think it has to be a good opportunity for Aurora, for you, what do you think is an adequate hiatal hernia repair during a major case like a bariatric operation that is going to happen afterwards?
So I do think you want to mobilize to get intra-abdominal esophagus, and you want to get several centimeters of that. I will also, on somebody who insists on a sleeve, if they have a small hiatal hernia, I'll be okay with that, but I'll do a posterior repair. And I started doing a modified Hill gastropexy, which is essentially getting the GE junction down to my repair to anchor that in so it heals into the abdomen to maintain that intra-abdominal esophageal length.
I will challenge you on just defining hiatal hernia repair, because I think part of the problem is how we're defining hiatal hernia, right? And so how we're approaching it, because just as we discussed, not every hiatal hernia is equal. And then especially when we're talking about these patients with severe obesity. I mean, if you see a Hill grade 2, is that really a hiatal hernia? Is that more of a mechanism of this intra-abdominal obesity? And is that really something that, we should be repairing versus let's see what happens with the weight loss?
Yeah, and especially because with weight loss, most of those people, their reflux symptoms get substantially better even with the sleeve.
Right.
You're decreasing the amount of upward thrust towards the esophagus, and the visceral fat mass goes down. So I do agree with that. I do think we need to be careful about what we define as a repair, going back to Sergio's point. I also agree with Aurora that I would do a posterior repair most of the time. And I'm just curious, your gastropexy stitch, are you trying to recreate the angle of His by doing that?
I'm really anchoring GE junction down.
Okay.
So basically, sometimes, you get there, you see the GE junction fairly in good position, but you make the dissection. You have a big lipoma posteriorly. And eventually, this is not a true lipoma, but some fat accumulation that is going to disappear afterwards. And then is going to appear the posterior dimple that we didn't see during the operation. So how would you manage these type of problems if you don't make not a massive, but detailed dissection of the cross, but at least you have to be more than just looking, oh, there's nothing, we go on with the operation. So how do you manage when you have these lipomas that you can reduce during the dissection of the crus?
Yeah, so I do think you want to reduce that mediastinal lipoma. I think that's a space, even after they lose weight, if you don't take that down and treat it like it's part of the stomach. So reduce it and then repair your defect.
Yeah, it's often attached to the phrenoesophageal ligament and fat pad anyway, so I think you kind of have to reduce it to be able to see the esophagus well and to know that you got adequate intra-abdominal esophagus. So I would agree.
Can I ask about medical management, and is there a time limit in your mind for how long a patient should stay on PPIs before considering surgery?
I think that depends really on their severity of symptoms, and I also think it depends on what your findings are in endoscopy. I think medically managing somebody with LA grade D esophagitis would be completely different than somebody with no esophagitis. So I really think the endoscopic findings and how comfortable they are and how well the meds control their symptoms would really drive that decision making.
Mamsi?
Yeah, I think it's been a great discussion, and certainly some of the elements that John brought up about positioning, self-reduction sort of ties into the element of, what is our definitions? And there's a poster downstairs about endoflip being discordant with our radiographic swallows for estimation of reflux. Whether we're defining it visually, we're defining it endoscopically, we're defining it radiographically. I think, that conversation is still very open. My personal bias is that dynamic studies are probably more accurate to true physiology, but we've gone to routine endoscopic evaluation on all of our pre-op bariatric patients, which has been very valuable, but I think we're still missing a subset. And I was just curious about what the panel's overall belief is how is the ideal assessment for these patients?
So, I don't do bariatric surgery, but I used to, and I now do a lot of endoscopy on bariatric patients and do some of the preoperative workup. I also have access to endoflip as part of my endoscopic suite as well as the OR. And I can tell you that I use it similar to how some surgeons use ultrasound, as an additional adjunct. I don't use it in place of anything, but I think it does give us additional information about functional activity of the esophagus. It is affected significantly by the anesthesia. So if you do general anesthesia and a lot of bariatric patients get general anesthesia, you may not see as much esophageal contraction. But then what it does allow me to do is make a decision if I'm going to subject the patient to further testing such as manometry for these tougher cases. And if it looks completely normal on my endoscopy, I will do less in terms of workup for that patient because I'm already doing the endoscopy. I have that information, like real-time information, like an ultrasound. And then I don't know about you all, but it's sometimes not 100% of the time that my patients will tolerate a manometry. I mean, anyone here have one? I mean, they don't love it. They don't love it. They're not like, can I do that again? So they're sedated, I do my endoflip, and if I get enough information, I don't subject them to manometry.
Yeah, I think you raise a good point, though. You know, the problem with gastroesophageal reflux disease is that it's a subjective disease. And so all of this testing that we're talking about are attempts to objectify our decision-making. And as surgeons, we're used to objective data to make decisions, but reflux is different. And I think, you know, more information is often better than less information. And that's not, again, not to abuse the healthcare system with excessive cost, but doing the wrong operation on a patient will only make them worse and leave your options to repair them later on down the line fewer. So, and to your point, you know, dynamic studies are helpful, but they're only reflective of that moment in time. You know, you get a pH study and you do it for 48 hours, and the first day the Meester score is 10, and you're like, well, I don't understand this, and then the next day it's 48. And had you only done a 24-hour study, you would have made the wrong decision, right? So the problem is that the severity of the disease waxes and wanes, and you're only measuring it at one point in time. So really everything we do is limited by a snapshot of that moment in time and may not represent the continuum of the disease.
Yeah, my point was just going to be if they know they want to bypass, though, I don't think you need all that testing because that's your backup if everything looks bad. So I don't feel like you have to do all of that on somebody wanting a bypass.
Agreed. Do you have any limit regarding your hiatal hernia size to say, well, I'm going to do a sleeve or I'm not going to do a sleeve?
If they have a hiatal hernia?
Yeah.
Well, the problem is if they, you know, the sleeve itself is a refluxogenic operation. It creates higher intragastric pressures, and many people without reflux pre-sleeve have it post-sleeve. So to add a refluxogenic operation to somebody that already has a reflux problem just doesn't compute to me. So I try to strongly discourage sleeve in that setting. Now, the question is, what if it's a really small defect and they have mild symptoms? Then I think it's a matter of an informed discussion with your patient as to the pros and cons of the different options. I think it's not unreasonable to consider there, but you have to counsel the patient that there's a risk that their reflux could worsen or that the sleeve could herniate up into their chest. And when you have that discussion, it's amazing how interested in bypass they get.
Now, John, there's a new procedure that they're talking about in Europe more than here, the Nissen sleeve. You talked about doing a Nissen on your patient and then staging to a sleeve. How do you feel like about combining those in one setting?
Yeah, I worry about it because you're leaving the fundus and cardia intact in the fundoplication. And so I don't know that you're going to get the same effect from the sleeve. The sleeve works because they fill their stomach very rapidly. The cardia stretches early into a meal and they achieve satiety. I don't know if they're going to achieve satiety as well. So I'm not a fan. I think this is going to be one of those fads that they do for a few years and then we get data on how terrible it is. And those of us that sort of just wait it out will weather that storm and not have to start doing it.
I agree.
So another question for all of you. What is the role of gastropexy? When do you decide to do it? Do you do it routinely, heel gastropexy, or you put a G-tube or anterior gastropexy? When do you decide that may be of benefit or never?
Well, a fitting question at the Pellegrini session because I do the Pellegrini gastropexy. I do it in all paraesophageal hernias unless they have a really bad reflux history on top of it, then I will consider a concurrent fundo. But otherwise, I gastropexy everybody and I do stitches from the left cruce all the way down to the costal margin and put the stomach anterior to the spleen with interrupted sutures. So I do it for all large hiatal hernia defects. How about you?
So I do a posterior gastropexy when I do a fundoplication of the wrap to the inferior diaphragmatic closure. And then on the sleeves, I'll do that modified hill if I've mobilized the esophagus, because I think there's nothing to anchor that down. And I worry that the big meal that they get in is going to push their esophagus up while things aren't scarred in and kind of reverse any of that esophageal mobilization, which is why I really like that pexy stitch, and I think that's made a difference, although I haven't studied it yet.
But you don't think sometimes, Aurora, that when you have a hiatal hernia that is big, you make the repair, the esophagus comes a little bit more anterior. And then when you do the PEXI, you create some kind of angulation. Do you think it make you sleep after this, or you will go home a little bit worried?
In general, if there's a big hiatal hernia, I don't do a sleeve. So I don't prefer that operation in combination. It's with a fundoplication with a wrap that I'll sew the wrap, and I don't think that causes as much angulation issue.
It will also the tension of the tension. Some pulling of the gastrocerebrostommy also helps with that function too. So for those that entered the room, I want to update you that we had two speakers that they couldn't come, but we are having a fantastic talk. So you're not missing the opportunity, please, to have something new to learn. So Kevin?
So we'll move on to our next speaker, who's actually going to combine robotic and laparoscopy, very, very timely, as well as open surgery. Dr. Melissa Hogue, who's director of HPB surgery and director of simulation, has been an international leader in training of robotics, specifically in HPB, really around the globe, and comes today to talk to us about how we educate fellows in robotic laparoscopy and open surgery from just a couple miles down the road in North Shore.
Hello, thanks everyone. Now it is, okay. So if it were, I guess, a lap versus robot versus endo debate, I win just by showing up.
Yeah, I think you win by default.
But sorry about the slide difficulty. Something got corrupted, so you know you're in Chicago when even your science slides get corrupted. But anyway, I say that as a Chicagoan. I'm going to talk today a little bit about training in robotics for fellowship in this Pellegrini session, combined SSAT SAGES, and I appreciate the privilege of the podium. I do get money to my institution for training with Intuitive. So I see my chair over there. I won't say anything, my old chair over there, Dr. Soper, so I won't say anything bad about my residency. But basically, when I was a resident, robotics was something the urologist did, and I spent my time in FLS in the sim lab, so he wasn't stomping his feet when I was doing my Nissen stitches in his OR. And in my entire fellowship, I only had one day in the operating room on the robot. In my residency. So in fellowship, my training was 2 hours online modules, 2 hours with the Intuitive rep. And I remember, the first time I did anything on the robot, as a fellow, I didn't know what I was doing, and I think I tore 6 stitches for the gastrojejunectomy of a Whipple before I got pulled from the console. But imagine that, how many stitches would you let someone rip, before you sort of rip them out of the surgery? So essentially, I then did a clinical research master's degree, and I took a class in curriculum development, and the needs assessment was the first thing that came up, and it said what was missing from your institution. And really, this is where development of a robotic training program was born, and really it was time for an evolution away from that see one, do one, teach one into some sort of formal training metrics. So what is the ideal training? How do we minimize the learning curve but maximize the emphasis on maintaining and improving outcomes? And a lot of this stuff is geared towards the Whipple, but if you could teach a Whipple, you can teach most other cases in similar manners. So, what makes a proficient surgeon? There's no one thing. You have to master the instruments, and for the robot, that's a console. You have to master the handling of tissue, and for a robot, there's no haptic feedback. You have to master the procedures, and here you're not really moving the bed and you're sort of fixed in a quadrant. You have to master the psychomotor performance, and a lot of faculty know that trainees forget their left hand, so let alone their right foot, their left foot, their third arm, and their camera. It's a lot of control, but surgeons love control, so there are some benefits to that as well. And then also just maintaining decision-making and judgment and ongoing QA, QI. So really the curriculum that I developed was focused on these things, So step 1 was the simulation curriculum in virtual reality, and this is how to master the console. Knowing how to do the console and knowing how to do virtual reality doesn't make you a better surgeon, but it makes you a better instrument operator. So the second step was inanimate curriculum. And part of this was deliberate practice, but part of it was also just learning how to get visual haptics and how to sort of feel with your eyes, as we say. The next step, 3, was a video library. The step 4 was a surgical curriculum. And then the step 5 was an ongoing QA, QI process, which I'll show you some data from that. So really, the virtuality, as I alluded to, was teaching the instrument, and it was a pre-test, post-test design, with a mastery-based curriculum. And then what we found, was that basically you're able to improve your performance, both in a virtual environment and an inanimate environment by doing this. But just the pros for those of you starting a curriculum or interested in it, a pre-test, post-test is good if you are testing something and studying it and doing research behind it. Inanimate testing is good as to add to a virtual reality so that you can measure change even when the simulators change. So now we're on the third iteration of the simulator. So it's like every time they change a simulator, you have to redo the study to validate it. But you don't have to do these things if your goal is just training and not research. You can do without. And then previous experience, I think, is actually less important at the novice and training level. Because, what I was finding with the fellows is the mode of cases that residents had done coming in was 0, and the range was anywhere from 0 to 118 cases. And this was a decade ago, so it'd be interesting to see how the landscape has changed over the last decade in terms of that. But then for this virtual reality, I created a checklist to make it easy for them to use. And then you move on to the biotissue, which I call developing visual haptics. And so I created these biotissue anastomosis simulating the reconstruction of a Whipple with a hepaticojejunostomy, gastrojejunostomy, and pancreaticojejunostomy. And so what we wanted to measure was technical skills, and so you could do OSATs or gears. We wanted to measure errors. Errors is harder to measure because it's a lot more video you have to watch, and it's a lot more subjective. And then you could do time. And what we found was that across the board, when all these anastomosis, you had an improvement in OSATs with the curriculum, you had a decrease in errors with the curriculum, and you had a decrease in time. And we did make attending gold standards, and what we found was that time was the most difficult metric for them to improve to the level of the attending gold standard. So this red box is basically they did not reach the time proficiency of an attending after 5 attempts, but for most of the other stuff they did. And so this can all, just to show this could be done for other things, now I do a lot more resident training. So here's an inguinal hernia model. Here's a ventral hernia model. So that's basically the same study, new statistician, so it's a different way of looking at the graph. But you have the dotted line was basically the attending median. So I had them do the drill and do that. And then you can see the little, from blue to brown is attempt 1 through 4. So you could see the steady improvement over time, and they're approaching the level of the attending. So both on the hernia, the inguinal hernia and the ventral hernia. So then the video library is really about surgical sequencing, but we all have seen these beautiful short-length videos that are presented at conferences that omit all the bleeding and all the thrashing and all that other stuff. So I think equally important to the short videos is basically I record all my videos, I put them on a YouTube, and I have like full length and then short, and so they could see uninterrupted video and watch it at whatever speed they want to, one, know how to do the operation the way you want to do it, but also be able to see sort of all the bumps and all the imperfection. And so the step 4 in terms of the simulation curriculum is coaching and what I call deliberate integration. So before I started this, I looked at our video library and I broke the Whipple down into 7 steps. The mobilization, the porta, the uncinate, the gallbladder, and then the anastomoses. And I looked at the min and the max, and then the median, And so we kind of developed time metrics from here. So the easiest and, sort of least possible for disaster, I guess, of anything here is the gallbladder. So we started them by doing the gallbladder and said they had about 10 minutes to do it. And the next thing was the gastrojejunostomy, then the hepaticojejunostomy, then the mobilization, then the porta, then the uncinate, and lastly the PJ. So we kind of had a plan. This is what you're going to do. This is how long you have to do it. And then you were able to see how they handled themselves and maneuvered on the gallbladder, and then how they stitched on the GJ before you would up the ante and the level of complications based on each part of the step. And so what we saw was that this improved fellow case consult time. So before the curriculum, if you look to see what percentage of the cases the fellows were involved in, it went from about 50% to 95% after the institution of the curriculum. If you look, and that's all surgeries, not just Whipples, so pancreas, gastric, colon, et cetera. In terms of Whipple steps, it went from about 20%, which is probably like gallbladder plus or minus GJ, to about 50% over time. And then if you looked at the resection, so the more difficult part to do technically, that over time about half of the resections were completed in their entirety by fellows. So what about ongoing QA/QI? I mean, a lot of people are worried about as you add training, it's different than it was maybe 20, 30 years ago where everything has scrutiny, especially when you're instituting new technology. So how do you prove that you're being safe and deliberate? And so this was I don't have the paper because I haven't published this yet, hopefully soon, just a couple rejections down. But we're looking to see, can simulation improve OR performance? So our hypothesis was that performance in the inanimate drills correlates with intraoperative performance for robotic Whipple. And so what we did was, obviously they did the virtual reality, the inanimate. We graded their performance in the biotissue. They went to the OR, and then we graded their performance in the OR doing the HJ and the GJ. And so what we found is essentially what you know intuitively, but and so like sometimes people hear this and be like, yeah, I would understand that. But the nice thing is that this is actually measured, and objectified. So one thing we looked at was we got everyone's ACGME case logs and looked at all the intra-abdominal operations. And so this wasn't like recall bias. We actually got their downloaded Excel file. So total residency cases actually correlated with the intraoperative performance. So something about understanding tissue planes and understanding the anatomy, et cetera. Performance on inanimate drills correlated with intraoperative performance. So you would expect that, and that was true. The sum of time spent in inanimate drills correlated with improvement on intraoperative performance. So you would hope that's true, and it was. And actually how soon people did the drills correlated with their intraoperative time. So if it had been a long time since they did anything in simulation, then their performance was worse. And I think just when you're an expert, you may be able to go longer time without doing something, but when you're a novice and a beginner, really the skills dwindle, and you have to keep that in mind. So what about, can simulation improve patient outcomes? So I looked at a study for learning curve for first generation Whipples, second generation Whipples, which I consider myself, and then third generation, which is our fellows. And then we looked at fistula, and we looked at morbidity, and there was no change in these three different generations. But we looked at time, conversion, EBL, lymph nodes, and length of stay. And despite onboarding new people to the technology, you were able to steadily improve each of these metrics throughout time. And so even just looking at the risk-adjusted learning curves, you could see just the people that started the Whipple program, 11 hours. But after mentorship, that came down to 7 hours. And after a simulation-based training program and mentorship, that came out to 6 hours. So we weren't reinventing that first generation learning curve with each surgeon that took on the procedure. So what about compliance? So, are residents interested in robotic training? I looked at this when I was at Pittsburgh, and I wanted to understand the resident attitudes towards learning robotics, perform a needs assessment, and determine adherence to a non-mandatory yet structured program. So 98% wanted to learn more. People were going into a lot of different things. Trauma, surgeon, colorectal, and peds were the top 4. 78% wanted to use robotics in their practice. So with these numbers in mind, we had 60 residents going through as a possibility in the 2-year time period. And then 60% never started a curriculum. 40% started, but 22% did not complete. So at the end of the day, in a 2-year time span, only 18% completed a voluntary training program. And so when we thought, well, what were the barriers to completion? They said time away from clinical responsibilities or research, location of the simulators, lack of priority. But I think this is just the problem that everyone faces in doing this in any sort of training program. And so then, if we had a lot of success in-house with fellows doing this program, it stands to reason you would go to some high-powered fellowship programs like Hopkins, Moffitt, Memorial Sloan Kettering, and have the same measure of success. And so I wrote a grant and got Intuitive to fund this longitudinal program. But what I found out was that only, 50% actually completed the simulation curriculum and 0 completed the biotissue curriculum. So kind of the rest was a wash after that. So really formal curriculums need buy-in, So, why train if I can't do the case? Why should I let them do the case if they're not competent? So at some point, something has to give first, but I think having the leadership buy-in to do the curriculum can kind of ease some of this. So, what are some learning strategies you could take for that? The carrot and the stick are sort of the common ones thought of. And so, I did have some corruption issues with my slides, I apologize. But, when you poll residents and say, what do you think is important? Do you think an open curriculum is important, or lab, or robot? They think everything's either extremely important or important. And I actually thought, and sorry if I didn't put endoscopy in here, that was a systematic error. I'll have to add to my next survey. But I think that I thought robotic was going to be deemed more important, not because I do a lot of robot surgery, but just that their access to it is so limited, where access to open and laparoscopy is higher. But I think because of how much more they do open and laparoscopy, that was deemed more important. So, I was able to have a second chance to do this residency curriculum. And then now I have a chair who's supportive and a pancreas surgeon, a program director who's supportive and a pancreas surgeon, a chair at another institute, who has an educational budget, that it's willing to spend it on this, and a pancreas surgeon. And then here, me, a pancreas surgeon that wants to do this. So kind of the stars align. You realize how much your leadership matters, and their mission to be your mission. And they all were supportive of robotics. So then, it was like, what do you want to do? And I said, well, I'd like to have my own 2-week rotation where it's non-clinical and they rotate through. So we have PGY3s rotate through for 2 weeks, and they do a curriculum that, goes through simulation and deliberate practice. When I first started, I had them come in my OR and do like one section of a case. And as it's grown and the PGY5s on my service did the PGY3 rotation, I don't let them do that anymore. But what we found is that, before I had this 2-week curriculum, I had something called the in-unit rotation. So when they were on my service, they had 2 hours of protected time every Monday to just work on this. And if we look to see if they did a 2-week rotation for the 2 years before we had this in full effect, they did the in-unit rotation, you could see that compliance with all 3 was, less than 30% for if they didn't have the dedicated time. And they were actually, they had the dedicated time, they were told to do it, they had it there, but if you weren't like constantly policing them, the compliance wasn't what you wanted. But when the in-unit residents completed 100%, they improved the OR time, OSATs, et cetera. And the ones that did not complete it obviously did not. And the average number of modules that we asked of them was 23, or we asked them to do 23, and the average that were completed were 10. However, if they did complete it, it only took 4 hours of their time, and they were able to finish it in 15 days, which is basically like 2 weeks, or 2 or 3 Mondays. However, when we do the dedicated curriculum, they finish it in 2 days. So, what we found, not surprisingly, that if you do the pre-test, post-test, the virtual reality improves, the OSATs improves, and the time goes down with this curriculum. But really, there's no difference in the pre-test for those with previous robotic experience. So I really think that at this level, it's not really the OR cases, which who knows how much they do and knows how much autonomy they have, but we do see that simulation does improve the performance, and it's more so if they master all the drills. So what are some lessons learned? So for those of you wanting to do a program or improving your program, the first thing, are what are the resources? And really the biggest resources is time. I actually get paid 0 for any of the time I put into doing a robotic residency education program. But, I do get research out of it and some other stuff, and it's something I want to do and feel for, but it's sort of a issue with healthcare with that. So really one of the biggest resources is someone who's willing to do this. Can industry be helpful? Are you doing this as a research like I am versus education, which I am as well? But if you're just doing it for education, there's ways to decrease the time input. Is this mandatory or is it encouraged? And this is really where that leadership discussion comes in. And is this protected time, which you can say you have 2 hours to go do this, or is it scheduled time? So sometimes people really need to be led to the water. And who's internally motivated? And I have at the top, a resident from Italy, a fellow from the UK, and a HPB surgeon from the Philippines. So I have people come through all the time to do this curriculum. I don't seek them out, but if people are willing to pay and fly out there and want to do the curriculum on their own, I have all the time for them. And that's another option on how to do it. Do not make it mandatory for everyone, but you put your time into the ones that are truly interested. So a couple tips: outsource basic training. So there's this Da Vinci online modules, and then I give this checklist to all the residents or fellows coming on service. And I'm like, do you know how to do all this stuff? I'll expect that you do. If you can't, on their first day, I'll have an intuitive rep go through all those things, but that I feel like should be on their time, not my time, not the patient's time. So that's one way to outsource that for you. Create a checklist. This could be very detailed, like on the left, or very simple, like on the right. But sometimes I just put this next to the robot and they just check it out, and it has their name on the top so that they know when they've done everything. Create a timetable. So this is challenging for residents, who may have 5 years, 7 years if they do research. Fellows, it could be simpler, especially if they have 1 year and you're just filling 12 months, or some, like Sir John Fellows, have 2 years. But I think it's really important to decide which milestones that you want them to hit and by when, and then sort of to be upfront about it when things start. Create a minimum threshold for the console. So that's the one thing I do, is that in order to sit at the console, you have to at least finish the simulation component of the curriculum. If not, you can't sit at the console. But you have to get buy-in from all the other attendings that are letting them sit at the console without doing anything. And so then create case logs or steps. So I kind of went through that earlier. There's like a deliberate integration of how to do that. And so I just kind of break up all my operations into procedures and by steps, and then we kind of talk about it, the night before. This is what you're going to do tomorrow in the OR, so the expectations are clear. And then with this integration strategy, as I told you, it sort of made sense to me how I would determine that, but whatever case you're doing, you would do what makes sense to you. And then one nice thing now, and I don't really utilize this as often as you could, but some people can more, is there's now this My Intuitive app where you can look and see that console 2 was me, where I said, okay, I'm going to do, mobilize the stomach, do all this and that, and then you're going to then do this part of the operation. And then every now and then there's a little help needed that you can jump in. But it took me about 10 seconds to open my app and click on one, and screenshot it. So this is a pretty easy metric, if you want to use that for your residents or fellows. And I mean, that's the goal. I mean, the carrot is doing the case, the stick is you don't get to do anything if you don't do the case, I guess. So people want to be involved. So when I started the program at Pittsburgh, and this was kind of when we were at 100 cases, and this is how case participation grew for Whipple's. This is how fellows percent per case grew, and this is how the resection grew over time. And because the goal is you want to graduate residents who then present their own learning curve after they're without you, and they could start these programs on their own. And like one of my favorite quote is, if they can make penicillin out of moldy bread, then they can sure make something out of you. And so in conclusion, implementing a structured robotic training program is challenging. I think proficiency-based testing will become an integral part of training. The problem is, how do we pay for it and how do we measure it effectively? But really, mechanisms to engage residents and fellows and boost motivation will facilitate the training. But most importantly is collaboration among programs is probably the most important. And so that leads to like 7 is do not reinvent the wheel. If someone has done it, ask for it. I've sent my videos, my surveys, I've sent everything to like dozens and dozens of people who are starting programs and ask for it. There's no reason to do something if someone already did it. And in 2012, when I was looking into this, I'm like, sure, the gynecologists and the urologists already have this program. I'm just going to put Whipple on it and, and change the name. but no one actually did. But now there's a lot of things out there, so there's no reason to go from scratch. Thank you.
Right.
Melissa Hogg, thank you for redefining the gold standard in simulation training science. I'd like to say the best way to handle a bias is really to provide great data. And what I'm interested in asking is, I've been training residents for 8 years in robotic surgery. My argument is I take the worst cases on the US-Mexico border, reoperative foregut, is that I can train people on the robot to be better at laparoscopy. And the only way we really address this is when we look at the experts in the room, Dr. Aurora Pryor and Dr. Romanelli and some of the leaders in SAGES, is how do we prove with studies that actually training on the robot and doing some of these difficult cases actually can make people exceptional at recognizing a hiatal hernia anatomy, performing a dissection, even performing the repair on a laparoscopic platform. And it's a reverse engineering question that I think has real potential.
Yeah, no, it's a good question. I'm going to sort of answer it backwards as well. So, I don't know that that's where the field will go. And the reason I say that is because I make people do open drills and I make people do lap drills. And then I kind of presented at SAGES and some other stuff that residents are voting with their feet that they want to do robot, not laparoscopy. Like across the board, when I do all these things, people don't want to go back. So it might be hard to teach them how to do it on the robot and then ask them to do it on laparoscopy. But if you're going to do it, I would say that it's still the same principles. You would want to start with the video, break it up to the steps, show them the anatomy. And part of my argument for this curriculum is that it's hard to teach HPB surgery and robotics at the same time. Let me teach them robotics here, and then bring them in my OR and teach them HPB surgery and robotics. And now if they know foregut, lap, robotics, and then bring them together, that's easier. So I think that if you're going to train them back to lap from doing this robotically, I think that you have to show them the anatomy and so that they understand the tissue planes. Because those redo operations, it's the tissue planes that are the hardest, and you could, you as a master, the panel as a master can sense when you're about to get in trouble. The residents and fellows, they can't, you know what I mean? But then in terms of, so it's part cognitive, and then part technical. And then I think for something like that, it's hard to simulate, but trying to develop some sort of model where the tissue is different, and then they have to kind of do the technical components of, exposure and stitching. But I don't know if I have anything more than that.
I can build on that because I think it's an interesting comment. I do a lot of robotic foregut as well. And I do think there is a role for reverse training because you're right. The amount of detail you can see when you do these foregut cases on the robot is so different. The other thing that I talk to the trainees about is this visual haptics, right? So on the robot, we depend so much on visual haptics, and you have to understand those cues of tension before the physical damage happens, which is a lot different when we do laparoscopy or open, where we're relying on the physical haptics. And so I almost say that on the robot, you're actually even more aware of the tissue and what the trauma you're putting on the tissue. And I think when it actually makes you a better laparoscopic and open surgeon because you're learning, it's almost higher acuity to some of these other senses that you didn't have to rely on before. And to your point about seeing more, even like seeing the knots go down square on the robot, the residents really learn how to do that on the robot, and I think it does translate really well back to laparoscopy. And it's an interesting concept if we can, like to your point about the learning curve, as we've done more and more cases of third generation, whether that learning curve with the robot will help our trainees now, maybe we can shorten, eventually maybe we can shorten our training programs because of this ability to shorten the learning curve.
I love that comment, and the amazing thing is that in the last 3 years I've had everyone except robotics, and I've had residents come back that rejected it initially and tell me how they adopted it later, and I was right.
Well, it's interesting. Dr. Pryor and I are talking about this up here. This year in the fellowship interviews, the number one question I'm getting is am I going to get straight stick laparoscopy? So after years of how much console time am I going to get? Now I'm getting, can I do it with straight sticks or do I have to do everything robotically? So even the trainees are beginning to sense that having both skill sets are going to make you a better surgeon. And, I think it's very astute that they're picking up on that even at this early age of their careers.
But I do worry. So Northwell has a really amazing data set, and I've gotten to look at it for some of these cases. And if you look at all the soft tissue cases, there's actually an improvement in robotic outcomes versus lap, and it comes down to the urologists and the gynecologists that can no longer operate laparoscopy.
Or never could.
Laparoscopically, or never could. But whatever it is, they show a difference in their outcomes. If you look at bariatrics or Porga, we don't. And that's because I think we still know how to do straight stick. But I worry in 10 years, that's not going to be the case. And maybe I shouldn't worry about it. Maybe that's just the evolution, but it's an interesting consideration.
And a compliment to you both. I always tell people when applying for bariatrics, once you know how to do it laparoscopically, the robot won't matter because it'll be so much easier. What I'm looking at is just specific places, like when Yeleni and I talk about reoperative hiatals, what's the benefit? There's expert pattern recognition, but there's always these principles of safe dissection, and just like critical view of safety, that won't change. The question is whether people can achieve retraction. And the robot on a BMI of 60 actually is quite difficult laparoscopically, but it's a beautiful teaching case with the robot.
So I just wanted to piggyback on Brian's comment and ask the panel for their thoughts. My observations, at least, are there's almost a bimodal learning curve to trainees adopting or relatively new to a robotic platform. I feel that the early introduction, in terms of teaching the anatomy and the dissection, as Brian had said, it's actually very favorable because there's no distraction from the surgical field as you're illustrating and educating them. But I feel like once you hand over the entire case to them, you get to that second mode of the learning curve where the cognitive workload of driving all the hands plus the camera, actually you have a different level of taxation that's a little bit different than laparoscopy, where you have a very active assistant. I was just curious whether the panel has any thoughts on that or experience.
So, sorry, the question was,
The question was, do you observe maybe a bimodal learning curve with learners from when they're sort of starting to learn robotics and appreciating the anatomy and the dissection versus when they get the entire case, including camera control and trying to navigate within, from multiple phases of an operation?
I think it depends on the complexity of what you're doing. A robot cholecystectomy is a totally different story than a robot Whipple. And so I think I understand where you're going with the question. On an easier technical case to perform laparoscopically, you can see them adopt the robot quickly. But when the case is technically difficult, it doesn't make it easier to be robotic. So I think, a robot Whipple is hard, no matter how you do it, no matter who does it. A laparoscopic Whipple is hard, no matter who does it. The robot might enable some of the suturing for the anastomoses. I would certainly think it would be easier, and I don't perform Whipples. I'm smart enough not to. But I don't think you see the resident adoption to robot get slowed down unless the case itself, like a gastric bypass, which is technically complex. Yeah, you'll start to see that. So I think starting them on easier cases or task-focused training, like Melissa described very beautifully, I think is the way to get over that.
I think, exactly, you split it up into task-focused parts of the case. And the other thing is, I kind of do the same thing I do with laparoscopy with robotics. At first, the residents just get the fourth arm, maybe if they haven't done a lot of robotics, so they're assisting me and they're not controlling everything. They're just controlling that one arm. Or I help them with the camera while they're doing some tasks, and it's progression, just like with laparoscopy in terms of the level of the resident.
I'm curious if Melissa does that too, where you give them the fourth arm while you're doing some of the...
I don't. It is a different train of thought. I know Rohan Jayarajan, that's sort of like how he trains. I'm more of like an all or none. They get the main part, and then It's also sometimes hard to have a bedside assistant and two people on the console. So a lot of times, when they're there, I'm at the body and they're at the console, and I can manipulate that third arm just at the body too. And then I have a kill switch on the camera to turn, to neutralize them if needed. But to answer your question too, is you definitely can see the learning curve progress. So I would say most of the time it takes about 3 months to get the fellows through a robot Whipple if they have sort of the aptitude for it. It hasn't been 100%, and I don't have those slides on here, but it's usually about 70 to 80%, will be able to get through an entire Whipple with you coaching them through it. And it was like early on, I kind of went through that slide fast, but the median time to get to the entire Whipple was about 5 cases, and they maybe did on average like 15 robot Whipples during that time frame. So that was sort of the time where they were, working out the kinks on the gallbladder, the HJ, the GJ, et cetera, before you were letting them near the big blood vessels. And then interestingly, as things went on, and towards the end of my time at Pittsburgh, the fellows were just having done so much in training. They would be on our service their second year, and they would spend the whole first year in the lab and do cases here and there. And so what we started finding my last couple years is they were sitting down at the beginning and then just doing the whole thing from the first time. And we had several do that. But it's something hard to quantify, in a publication. But you can see kind of the learning curve come through. But it's all different facets. And even though suturing is a totally different skill set than the dissection, it translates, because it's how do you move the wrist, how do you be efficient, how do you, a lot of laparoscopy shoulders, right, where a lot of robot is like open, where it's wrist movement. So a lot of times you're watching the robot arms like this, and I'm always like, supinate, pronate, you're trying to move them around. So yeah, you can definitely see how things go, and I think you could decrease the learning curve dramatically, and I've seen that just with as I add the training on, because it started with simulation, that added biotissue, and then kept going from there.
Yeah, I think one thing I would add, just from a training standpoint, and some of these requests about doing more laparoscopy, we have a resident who's applying right now, and that's been one of the things that I'm looking for, a place that has access to laparoscopy, robotics, and endoscopy in some sense, but we're really at this inflection point where access is still extremely variable, depending on where you end up at the end of your training. And I think they see that the closer they get to the end, is that it's not like every place has easy access. And so at the end, you want to provide minimally invasive surgery to your patients. And if you kind of hamstring yourself by only providing one modality, where you end up, it might be hard, because it's not a quick thing where you can just pick up, and say, I'm going to do robotic X, whatever that might be. And so I think they're starting to see that you really have to have some flexibility in how you can tackle things, laparoscopically, robotically, open, endoscopically. And I know we didn't get to talk about endoscopy, but I mean, we're at a meeting where we have rooms full of people doing endoscopic procedures for what we used to do in an open fashion, or now laparoscopic fashion and robotic fashion. And I think as surgeons, it really behooves us to continue to keep our feet in all of those areas, especially as it relates to training, and making sure that those who have the drive to do those things have teachers that are willing to teach them in that way.
I also think it's going to change as more robots come on the market. So it's
but that's a while away. I mean, that's why I think we're in this very weird place.
Yeah,
where
it's not that far away, though.
But they're going to graduate next year. They're going to graduate in 3 years. And in 3 years, they're not going to be a plethora of robots, because the robotic representatives say, well, why do you treat the robot any differently than laparoscopy? It's a limited resource.
Let me give you 2.9 million reasons.
Right. Yeah. In laparoscopy, laparoscopy used to be a limited resource, but never in the way that robotics has been.
That's
never.
True.
It went very quickly from, we had little access, but then it really was, because it wasn't as expensive. I mean, that's the reality. We were able to buy bigger towers for more rooms, and Granted, we have people in the room who know that it was a limited resource at a time, but not nearly the length of time that it's been a limited resource. How many years now? Decades of limited resource.
Yeah, but I think we're much closer at this point now to
But
getting,
decades of a limited resource.
Yeah, but I think now we're at the point, we're going to get these new platforms. I think it'll change, but agreed, it's still a limited resource at this point.
And from a leadership standpoint, also you have to look at the finances and some of the things that people are doing, and you spend hours more as you're learning doing a inguinal hernia or a gallbladder on the robot, and it makes no financial sense for a hospital. So I do think we have to look at some of the things that we're advocating for and be smart.
That's right. It's strategic use of the resource is what's important.
Onur Kutlu, University of Miami. So I was going to say just what Rory said. Basically, things are going to be economy driven. Robot is a valuable resource. Let's say that you even have a $2.9 million. Let's say the company gave it free to you. Looking at the data, each case for gallbladder costs $700 more just in terms of the covering of the robot and other things. So the hospital administrations and then bean counters are going to go after that. So I think staying with the stick versus the robot is going to be a pure economically driven thing. But I also want to ask something to Melissa and Kevin, because I know that you both do robotic Whipples. The robotic Whipple, as you know, it's a very suction heavy operation. And you have to have
only when Melissa does it. Mine are more bloodless.
Yeah. Well, I even put like 10 Ratex in there. So anyway, having a resident by the bedside with the bulky robot and the arms are moving and hitting them with the suction it's pretty hard for them, and they often complain about being exposed to the robot too much. So how do you get the buy-in from the residents for this? Because gastrectomies are easy. You rarely use the robot, and I use them. You rarely use the suction, so I use it to train the residents.
Yeah, I mean, a lot of criticism, that our technique for the robot Whipple is that it requires two people, one at the bedside with advanced skills and one at the robot, where some people want to advocate for just needing a nurse assist at the bedside. I don't really agree with that, for a lot of reasons, because that's not how we do it open. I think that there are ways for port placement, I call it the robot space and the lab space, and so part of that is port placement, so do you still get knocked around a couple times? Sure, but with port placement, about 80-90% of the time, you should be okay with that. In terms of the buy-in, I think that if you're having a resident assist and all they do is exchange instruments, it's only going to be so long before they want to shove you off the roof, of the hospital,
Yes.
So I think that for me, for like a Whipple, it's pretty advanced stuff they're doing. I mean, they're GDAing, or they're taking the ligature, the epiploic off of the portosplinal confluence, you know what I mean? They're stapling the GDA, they're stapling the bile duct. They're kind of doing more advanced laparoscopy stuff. They're pushing around the neck of the pancreas and getting under. So it's not like low-level laparoscopic skill of just suctioning. And then also you got to get them on the robot. You know what I mean? If I had them do that for 6 hours, they may not want to show me off the roof, but maybe like a small platform, So I think that, they're kind of going through the resection, and in hopes to get to be able to do the gallbladder, the HJ, and the GJ. And I think for them, that's a good mix, because for a resident doing, 1 month on service, you're not going to be able to teach them how to do a resection or a dissection. And that's just the reality of it. And that's why we have fellowships these days.
One more thing is, I think the value also of robotic surgery is you can have feedback. Everybody can know in real time how they are doing. Before, it was kind of your mental perception. So since we have many people in the room that have been from, I don't mean this in age, but I mean this in experience. So are we learning from the way you try to transition from open to laparoscopy? Are we using that experience to transition now laparoscopy to robotics? Or is a completely different process?
That's I think what robot is hard. I think it's a completely different process because when you're like hand to hand, face to face, I mean, I'm sure everyone has gotten like head-butted by someone's like headlight. There's kind of like your headspace, my headspace. So you're face to face and you're directly there. You're stopping them, and then with laparoscopy, a little bit of that too. But the robot, one's scrubbed, one's not scrubbed. You're across the room. So I think the communication and the interchange is a lot different, and I always say that once a resident or fellow gets behind the console, all of a sudden they used to be able to hear, and all of a sudden they become deaf, because I think that so much of their attention capacity, which Satava's talked about so much, is going into just thinking about how to move my hands, how to move my feet, how to clutch, how to do this stuff, that they don't have the attention capacity to listen. So I'm like, stop. Take your head out, you know what I mean? And then I talk to them and then let them go, put their head back in. But you don't have to do that for open. You don't have to do that for lap. I mean, I've seen senior surgeons who are experts at open or experts at lap, then they're the robot, they forget they have a left hand. You know what I mean? So it's just, there's some sort of extra thing that makes it a little bit more difficult where you take the skills that you have, but you relearn several of them too.
The other thing is, I think we are not at the peak of the technology, not even close. And at some point, it's going to be a breaking point that really technology is going to improve significantly. I'm not a robotic surgeon. I have Kevin for that. But let me tell you, it's different. It's very difficult when you are not that young to transition to robotics. So. And nowadays we have residents of different ages. So how do you teach those trainees that on different level of experience?
Yeah, no, it's interesting. I've done a lot of like training of attending surgeons, and some of them I'm very junior to. So you're used to talking to your fellows and occasionally a 4-letter word might slip out, but then when you're talking to a professor, I mean, when there's portal vein bleeding, your vocab is like very limited for a short period of time. But when you're talking to then senior surgeons, it's more like, oh, careful, like I wouldn't do that. But one thing I've noticed is that you have a senior surgeon who's very confident that they know the tissue planes, they know the operation. So as they start, they're a lot bolder. You know what I mean? They're like charging in there. They don't have the haptic feedback. They may not have the technical prowess, but they have a lot of other stuff that emboldens them. Where, I say they go charging in like Zorro with all the instruments right towards stuff. And then you'll have the fellows and residents who are like almost not touching anything. And I say it's like a kitty cat that's like kneading the tissue because they don't really know how hard to push it. So it is definitely a different thing. But I don't find that older, more senior surgeons have trouble picking up the technology. You know what I mean? I find that they're less cautious in some regards, to approach it because they know the operation, they know the tissue planes, they know all the stuff, and so they have to just let the just nuts and bolts of the technology in. But people pick it up easy, and that's why a lot of people are going from open to robot and skipping lap. But you see a lot of differences, so like the Dutch surgeons were doing laparoscopic Whipples, and I went in there and taught a bunch of them how to do robotic Whipples, and then because of bad outcomes, the lap Whipple program got shut down, and so then I went in and taught the lap Whipple surgeons how to do robot, and they picked it up so much faster. You know what I mean? So there's all these things to consider. In this, but I definitely, and my boss is 67, and he picked this up when he was 60. He came to Pittsburgh, spent a month, learned the technology, and then started doing it. So I don't think age is a deterrent. It's just motivation is the deterrent, because I think that, a little bit of input goes a long way in terms of the training, even if you're a senior surgeon. But most senior surgeons don't have the time for that.
I will say my senior partner, John Alverdi, picked up robot in his last couple of years of clinical practice, and he wrote a really nice editorial in JOGS. He became a total lover of robotics, and he adapted very quickly. Obviously, he's an expert laparoscopic surgeon, and now he's just like never going back. but he's clinically retired now. But I will say it was interesting to watch how fascinated he was by how much he could do and how, with the training, the robotic changes.
What about, just for the completion of the program, what about the teaching and training residents with more and more endoscopic technology?
Yeah, I mean, so I think you'd asked me to kind of think about this, and part of it is because when I was a resident, I was really trained by surgeons who believed that surgeons should be holding the scope. If they were holding the knife, they should hold the scope. And so a unique fellowship was available, which was an flexible endoscopic fellowship, and I think in that fellowship, learning the basics and even advanced endoscopy. But with all of the things that have shifted toward endoscopic surgery, like POEM and POP and some of these things that used to be done, as I said, laparoscopically and even in robotically now, I think that these are going to be similar to how we saw things like laparoscopic cholecystectomy get picked up, is definitely courses, longitudinal training, fundamentals of endoscopic surgery for those who haven't done it, outside of, finishing, once they've finished. But I do think for fellows or residents is identifying programs that include endoscopy, I think is really vital. And again, I realize that that's variable as well.
One comment on that's a little bit tricky, and sorry, Brian, we'll get to you in a second, is when we started doing these things collaboratively with GI, they are often the triage for some of these disease processes. And when we shared, like POEM, for instance, with GI, I got the comment back, why would we ever give that business to you when we can manage it ourselves? And so I think bariatric endoscopy is actually a really nice segue that you can get a lot of these advanced skills and train your residents and treat your patients. So I do think that's something we should definitely be keeping in our armamentarium and getting our trainees involved with, because we are the gatekeeper there.
Absolutely.
So I just finished reading a paper in gastrointestinal endoscopy, how the learning curve with endoscopic ultrasound is decreased with people that have an innate of both sides of the anatomy. What I'd like to say is someone who's trained both GI fellows and surgeons on ERCP, there's less cognitive tunneling when trying to teach a surgical resident. I've got my surgery resident sitting here in the third row, ERCP, because there's lower numbers and less of a learning curve because they understand both sides of the anatomy. Dr. El Hayek, you trained with Jeff Ponsky and I with Vitali. What do you think about the concept of proving that people that train in laparoscopy and robotics actually have a lower learning curve for learning to be competent in endoscopic therapy?
Yeah, and I think that's where EPA's, which is the new initiative by the American Board of Surgery, is set to challenge a numbers-only competency-based training, which I think came out of the thin air, bad studies, and then these crazy numbers were submitted and now are part of competency evaluations at hospitals, like 250 of what have we had to do 250 of other than robotic Whipple in the first generation of surgeons that we needed to do 250 of when we're using our hands every day. And so I think EPA is hopefully going to address that, where there are going to be some people who get there in 10 cases and some people who get there in 20, but ultimately having a video-based assessment of what they're doing, a quality initiative, more systematic way of assessing what people are doing versus, oh yeah, he's good or she's good, right? Which is how things used to be decided. And then it became, you need to do 250 of them, which is like pretty significant pendulums.
So based on your response, we have FLS, we have FUSE, they are not procedure specific. Should we have certification on residents going to a specific area, having been tested with procedure-specific testing or certification?
I'm a believer in that. I think, SAGES has developed a procedure-specific foregut video assessment that's really pretty good and pretty validated, and we're planning to roll that out with the fellows that are completing foregut and MIS fellowships, and I think that it'll be a very good first step. From the Board of Surgery standpoint, we think the most appropriate early assessment is actually in the focused practice designation in bariatric and metabolic surgery, where we have a group of people that can all do things in a minimally invasive fashion, robotic or laparoscopic, and that rollout of that assessment, I think, might actually be the first high-stakes exam in this space. So I think that's pretty exciting. I can see lap chole being a threshold for graduating residents, and SAGES is working on that now. So I think these things are coming.
I mean, ASMBS had that pilot program as well. I don't know if anybody knows what happened to it in terms of the number of anastomoses. Instead of having this, random number of anastomoses, it was more of like an EPA situation where the program director evaluated the fellow on 10 cases, and I think there were some programs that participated in that pilot program, but I don't know what happened to it.
Yeah, I don't know.
And the acronym EPA is Entrustable Professional Activities, which I know there's so many acronyms that we use, and this is being rolled out like imminently within like the next week or whatever. It's because I heard from Dr. Mellinger, who presented at our grand rounds last week, is like anytime now it's going to get launched.
Yeah, for any of
Like
you who
Monday.
don't know, there's information about it on the American Board of Surgery website. They're trying to do teaching seminars and grand rounds for any teaching institution who's interested in learning about it. So please ask. I'm one of the speakers. Yeah.
For the next half hour, we're going to hear about EPAs from Dr. Aurora.
So all of you are very involved with SMBS, SSAT, SAGES, and I think virtuality came and will stay forever, I guess, right? But so far we have been focused on how we can deliver theoretical knowledge through a teleconference. What do you think is the future on telementoring or telecoaching to complete this circle? Because evidently there is less people not in this meeting but in every surgical meeting because of multiple reasons. The pandemic changed in many ways and the way we perform, we do things, even some people they have different set of values, whatever you want to call it. So how do you think telementoring, telecoaching in the next couple of years is going to be very important? When I came to United States, I remember it was a couple of months after Gagne did a transatlantic cholecystectomy, right? And that time it was fiction. It was like Indiana Jones movie, but in medicine. And it was not realistic. And however, this doesn't sound that unrealistic right now. So tell us the future.
Yeah, I actually think it's great technology. I think this is one of the things that we learned during COVID that made a difference for us. I know my personal first experience was I was actually supposed to be teaching a bariatric revision course at my institution. Of course, I had COVID. And so we luckily had one of the companies set up that I could actually still teach and telestrate and have a dialogue. And my partner was doing the cases, and it was very interactive. I thought it was fabulous. And the other thing is, I think as we get bigger and bigger systems and you get more and more people that are off at a remote institution doing something, I think you can actually be a supportive partner from hours away and be in that OR with that person, and you could potentially avoid some of the complications that before you had to drain and refer. And I think that would be a huge thing. And then as you roll out new procedures, and we've had proctors required for these, like if you do your robotics cases and nobody in your institution did robotics, we used to have somebody come, I think you can do that remotely. And I think it's actually probably adequate, and that dialogue is pretty good. So hopefully that's lasting.
I think we've had some really good discussion here today, and we won't keep everyone any longer in this Monday afternoon. Thank you all for bearing with us with some of the changes to the panel, but I think we all enjoyed it. So thank you. Have a good afternoon.